So Dr. Timchak, who's our divisional head, was to give this talk, but he had a medical issue and couldn't make it. So I'm kind of doing a makeshift thing at the last minute. Most of the slides are what he had kind of prepared. So the Heart Institute in Edmonton, where we work. So nitrate in ischemic heart disease has been there for a long, long time. Basically, the use of nitroglycerin and angina pectoris, the diagnosis went kind of hand in hand. And for a long time, everybody believed that the nitroglycerin opened up the coronaries, got rid of the angina, and prevented imminent demise. So one had to carry the nitroglycerin close to the heart for a that was the standard type of practice. Indeed, sublingual nitroglycerin relieves attacks of angina very, very effectively when they do occur. And they are also quite useful in preventing attacks of angina during exertion when you take it beforehand. So it's quite effective treatment. Given these observations, it was thought that the benefit in the setting of a heart attack was going to be the same. So it was assumed to be efficacious and never doubted. How do the nitroglycerin produce benefits? First of all, it's known to dilate the large coronary arteries and the arterioles greater than 100 microns, which may lead to an increased perfusion of the ischemic zones. They certainly dilate the veins with decreased preload, with a reduction in ventricular volume, the pulmonary capillary wedge pressures. This effect can be quite useful in people with concomitant pulmonary congestion. They also do dilate the systemic circulation and decrease the afterload, although this effect occurs generally with higher blood concentration, so thus higher doses. And this will obviously help to lower wall stress, oxygen consumption, and so on. In experimental animals, they have been shown to decrease infarct size and infarct expansion as well. And they will terminate any episodes of angina where it is related to coronary artery, purely coronary artery spasm as well. And it's also known to enhance any collateral blood flow. How do the nitrates act at the cellular level? They enter the vascular smooth muscle cells and combine with sulfhydryl groups, forming nitrosothiols. The nitrosothiols in turn stimulate guanylate cyclase to produce cyclic GMP, and this results in a smooth muscle cell relaxation by decreasing intracellular calcium. But just like statins, they may have additional effects as well in terms of antiplatelet, antithrombotic properties, and whether these properties have any clinical significance remains unclear. Stimulation of platelet guanylate cyclase by nitrates prevents fibrinogen binding at the glycoprotein 2B3A receptor, which is the common pathway, final common pathway of platelet aggregation, and thus may minimize platelet aggregation as well. If you look at the guidelines with regards to use of nitrates, the 2004 guidelines, looked at the nitrates in ST elevation, myocardial infarction. In the 2003 guidelines, there wasn't much change made to the original observations. Nitrates are known to ameliorate symptoms of myocardial ischemia by reducing preload and increasing coronary blood flow. They necessarily do not attenuate myocardial injury associated with epicardial coronary artery occlusion unless the vasospasm plays a significant role. Intravenous nitroglycerin we can obviously use to treat acute MI as well as hypertension, heart failure associated with an MI. And we also know nitrates should not be given to patients with hypotension, marked bradycardia or tachycardia, RV infarction, and those who have used the phosphodiesterase inhibitor within the preceding 24 to 48 hours. And there is not a role, there's not much role in the convalescent phase. Nitrates, just like anything else, if you're using, it's important not to use in patients with hypotension when they're present with an MI, and that goes universally with beta blockers, ACE inhibitors. All these medications which can drop the blood pressure may make prognosis worse and infarct size worse if you give it to people with hypotension. Even if you looked at the ACE inhibitors, the only trial of ACE inhibitors that was shown to be or was stopped because it was not going to show any benefit, possibly adverse, was the consensus 2 trial where everybody who came in with an MI was given an ACE inhibitor. So all these drugs, one has to be careful based on blood pressure. The intravenous nitroglycerin certainly became use became widespread because of the mechanistic data demonstrating benefit on infarct size reduction and subsequently on infarct expansion, what we call remodeling of the heart. After a heart attack, the heart tends to get bigger in terms of the infarcted area expanding, and ultimately, based on the size of the infarct, can form an aneurysm. But also the non-infarcted area gets bigger over time, and these usually occur with larger MIs. And numerous pioneering studies, actually quite a lot of them were done in Edmonton by Dr. Jagdat, showed that this infarct expansion was lessened by nitroglycerin. There was fairly good animal data. Human data was not so definitive because this was the era of not large trials, mostly observational trials. However, most of these trials were published in peer-reviewed journals, excellent journals at that time. So it became the kind of go-to drug, certainly in the 1980s, when anybody walked in with an MI, and even prior to the thrombolytic area. Practically everybody got intravenous nitro, and even those who developed severe bradycardia, hypotension as a complication of nitroglycerin, we used to re-administer, and many of these, the second time round, had no issues with the use of the nitroglycerin. And then morphine got relegated to a kind of background role. And at that time, most of the academicians, many could have been non-practicing in terms of dealing with that many patients, strongly recommended its use. So the IV nitroglycerin was initiated in patients with ischemic pain. The usual thing was to give some nitroglycerin tablets, 2 to 3 tablets, and with the adjunctive therapies, and if there was no response at that point, they were started on an IV nitroglycerin drip. If you then looked at the actual efficacy, despite extensive clinical use, there was little objective information documenting that this strategy did anything to the patients in terms of mortality or serious morbidity reductions. Several small-scale trials had evaluated open-label infusion of nitroglycerin to reduce the frequency of the pain, and symptomatic relief was kind of noted in these reports. But obviously, being open-label trials, it is, and the history of nitroglycerin, where everybody kind of believed it helps the heart, it was very difficult to evaluate whether there was proper efficacy or not. What about the trials? So the GISSI-3 trial looked at the effects of lisinopril and transdermal nitroglycerin singly and together on a 6-week mortality and ventricular function after acute MI, published in 1994. What it showed was the lisinopril was effective in terms of cumulative survival, but the nitrates did not have any significant benefit over a 42-day time period. And the summary was that the primary endpoint was obviously not met for the nitroglycerin group. although the subset of people who received lisinopril and nitrates both tended to have the lowest mortality in the trial with odds ratio of around 0.83 compared to 0.88 for lisinopril. It wasn't significant, but there was a suggestion there could be a possible additive benefit. The nitrate patch in this trial was discontinued at 6 weeks, and longer-term follow-up of the data at 6 months showed no difference in mortality or left ventricular dysfunction in the patients who received nitrates. Then another trial was published looking at ISIS-4, looking at 58,000 patients, again investigating in a factorial design captopril, oral, mononitrate, and intravenous magnesium. And this shows the 35-day mortality in the groups, looking at captopril versus the mononitrate and the magnesium. Magnesium was not shown, possibly increasing adverse outcomes. There was no significant difference with the nitroglycerin preparation either, with the captopril showing benefit. So again, there was a large-scale trial here not showing any benefit. And then they looked at various combinations of these agents, because it was a 2 by 2 by 2 factorial. There really didn't seem to be any difference favoring nitroglycerin. Again, there was a 12-month extension in terms of the trial to look at the benefits, showing that overall, even at the end of 12 months, there was no difference in the outcomes. So basically, the primary endpoint on this trial was a 35-day mortality, and the nitrates were not withheld from the control group with appropriate clinical indications such as worsening pain, heart failure, and so on. But similar to the GISSI-3 trial, there was a substantial crossover in the patients, in the sense that the patients in the control group, a fair number got some nitroglycerin preparation during the course of the study, obviously diluting the the difference between the two groups. But the bottom line was there was no significant difference in mortality at 35 days or at 12 months. How do we use nitroglycerin? The intravenous nitroglycerin, when we use it, we titrate based on the blood pressure response. So usually the recommendation is to produce a 10% reduction in the mean arterial blood pressure if we're just using to, as a adjunct to saying that giving IV nitroglycerin will help to minimize outcomes or the adverse outcomes, is to reduce the mean pressure by 10% in normotensive patients and 25 to 30% in hypertensive patients. And generally the blood pressure lowering should be done in a very gradual manner, and the recommendation is that you do not lower the blood pressure beyond these levels, and the systolic blood pressure should not fall below 90 or more by more than 30 millimeters. And it started as a 5 to 10 microgram per minute infusion, and we increase it by 5 micrograms up to 20 micrograms every 5 to 10 minutes. And one can go up to very high doses, although most of the time these days one doesn't end up going up to that kind of doses because of the availability of getting a patient to the cath lab. And infusion generally has been used for 48 hours for persistent ischemia, heart failure, hypertension, and so on, but tolerance develops over this time. It can be obviously given later on as well to control ischemia, but most of the time, again, these days, patient would have had an angiogram and revascularization, so ongoing ischemia is not an issue, other than in an elderly patient whom we are not going to do angiograms, or who has had an angiogram, no revascularization is possible. One important caveat is if you are using nitroglycerin, it should not preclude therapy with beta blockers, angiotensin converting enzymes, inhibitors, etc., because these drugs clearly have been shown to alter mortality and morbidity. As said before, it should be avoided in the setting of any hypotension, marked bradycardia, known and suspected right ventricular infarction, and then patients who have taken a phosphodiesterase inhibitor and so on. Obviously, if they've had severe aortic stenosis, hypertrophic cardiomyopathy and so on, as a primary diagnosis that is already available, again, nitrates are not the best to give. What about the nitrate tolerance? It's a fairly incompletely kind of understood phenomenon. It is a real phenomenon in the sense that attenuation of the vascular effects certainly occur over a 24, 48, 72-hour period. There is impaired nitroglycerin bioconversion to 1,2-glyceryl dinitrate with decreased formation of nitric oxide, and there's reduction in the formation of S-nitrosothials, possibly due to lack of sulfhydryl groups. And this is something that's not seen with nitroprusside. Obviously, the bottom line is ultimately there is reduced bioactivity of the nitric oxide, and there have been some medications that have been tried to see whether we could really minimize nitrate tolerance or delay, and it hasn't been shown to be, or none of the drugs have been shown to be of any real benefit. So most patients, when you give an infusion, tend to lose some efficacy within the 24 hours. And if you looked at the GISSI-3 trial, the blood pressure lowering effects was lost within 24 hours. However, these days, prolonged nitroglycerin is not needed, generally not needed, so this is not much of an issue. So the only way to deal with nitrate tolerance is obviously to give intermittent therapy, allowing for the regeneration of the sulfhydryl groups. Obviously, this automatically means there will be a nitrate-free period where there could be rebound angina. Or you have to use higher doses, obviously, if you're giving it continuously in the initial period. And as I said before, giving N-acetylcysteine and so on to hopefully replace sulfhydryl groups has not been shown to be beneficial. Several experimental therapies have been assessed, but nothing convincing to really get rid of this problem. There's also a reduced response of nitroglycerin noted in Asians. The formation of nitric oxide from nitroglycerin is dependent on this enzyme mitochondrial aldehyde dehydrogenase. A polymorphism of this enzyme is present in about 30 to 50% of Asians and virtually eliminates the activity and the nitric oxide production. And in one study from China, 41% had at least one of these alleles, which obviously would mean there's less response. So what is the bottom line with nitroglycerin these days, certainly in terms of management? I think there's only very little role if you look at ST elevation MI. Ongoing pain with an ST elevation MI indicates an occluded artery, thus the need for urgent revascularization. I think nitroglycerin is a very, very poor in terms of controlling the pain, basically useless, I think, in a ST elevation MI. And attempt to revascularize while giving other drugs ahead of nitrates, is the way to go, because otherwise you will end up with, wasting time giving nitroglycerin. Much more positive data is there, with these other drugs. And also titration, as I said, takes a fair amount of time during these busy periods. So I think the bottom line ultimately would be using a narcotic if the pain control is necessary is a better approach than using any intravenous nitroglycerin. So we hardly ever start IV nitroglycerin in ST elevation MIs just for the control of pain. Obviously, if there is significant hypertension, that you have to control and so on, where titration becomes easier, that's a separate issue, and if there's ongoing failure and so on. But clearly the beta blockers, ACE inhibitors and so on, if the blood pressure is high, would be the way to go first, but nitroglycerin is certainly easily titratable. What about in non-ST elevation and unstable angina, the patients who present? It's quite effective in relieving pain or preventing or minimizing recurrence of the chest pain in this setting. Most of these patients are pain-free by the time they reach the ER or with a few tablets of sublingual nitroglycerin. And this is maybe related to the fact that the occlusion is either subtotal or, on the other hand, transient. If they are pain-free at the time, we often would use a nitroglycerin preparation, mostly transdermal nitroglycerin, to minimize the recurrence of the pain while we are obviously administering the other treatments. Big advantage of nitroglycerin is way faster acting as an anti-anginal agent than a beta blocker or a calcium channel blocker. So we would start off with transdermal nitroglycerin instead of IV nitro, and if they continue to have further pain, then switch to IV nitro, which is obviously easily titratable. Continuing pain obviously kind of implies reocclusion, thus the need for urgent angiography. Now when we're using transdermal nitroglycerin in the emergency, just like IV nitroglycerin, it should be used continuously. We don't write, and I see this as an error, lots of people writing a transdermal nitroglycerin order in the patients who come in with unstable angina or non-ST elevation MI for 12 hours. Because if you do that, they are going to have rebound ischemia and angina, which is not appropriate to precipitate during that time period. So I think if you're writing it, it should be written as a 24-hour, continuous patch replaced every 24 hours, and the patch will last way more than 24 hours in terms of delivery of the compound. And in the post-acute phase, and initially, as I said, we use it as a continuous infusion or continuous transdermal nitroglycerin, and at 48 to 72 hours, you have to make a decision in view of tolerance. Mostly people are pain-free at this juncture as a result of angios, revascularization, and even otherwise, you have started the beta blocker, the other anti-anginal agents, which are much slower acting, but within 24 to 48 hours, they have had their action, really cemented, and the transdermal nitroglycerin can be taken off, or any nitroglycerin. I think if you look at the long term, there's fairly good evidence that there is lack of benefit other than symptom control. So there is really no need to use any nitroglycerin preparation in ahead of like a beta blockers, ACE inhibitors, calcium channel blockers for control of angina, the beta blockers and the calcium channel blockers. And obviously all these three compounds, the ACE inhibitor and the beta blockers, together with calcium channel blockers in a few settings, have much better, efficacy in terms of secondary prevention, hypertension control, etc. Only indication, I suppose, on the long term would be in those with continuing angina who cannot be revascularized. In this setting also, I would use it as a third line agent, giving beta blocker and the calcium channel blocker first, because of the fact that you will have a period of lack of control within each 24-hour period with rebound ischemia and angina. About it, there's not a lot to say about nitroglycerin. It's used less and less overall, other than in the outpatient setting as a control for symptoms as they occur.
Thank you.